a virtual mode. So I
Okay.
think we have few people who are joined.
Okay.
We have 3 cases today. I'm really happy that Dr. Sheshadri, my teacher, could be here with us today. And I would also request him to come in and comment on the cases that are being presented. Osborn, as you start, can you just introduce yourself so Dr. Sheshadri knows which year you are in and where you're posted?
Osborn, first year PG registrar.
Just speak a little louder. Yeah.
So I'm Osborn, first year PG registrar. I'll be presenting Rush on behalf of Medicine 3. So this is M, 25 years old lady, primi gravida, 28 plus 2 weeks gestation, came for routine antenatal checkup from Tiruchirappalli. She just came for routine antenatal checkup. She didn't have any complaints of breathlessness, chest pain, fatigability, no syncopal attacks, no fever, no history of bleeding, PU, or white discharge per vagina. Obstetric history at 5th month. Patient was started on tab metformin 250 mg OD and stopped after 2 weeks and now currently on MNT.
You can speak slowly.
MNT. There is no family history of heart disease. On general examination, vitals, pulse rate was 100 beats per minute, regular in rhythm, bounding pulse, right radial artery, measured blood pressure on right upper limb and left upper limb was 120 by 70 and right lower limb, left lower limb was 90, systolic BP. Peripheral pulses, all were palpable. However, the lower limb pulses, the bilateral, femoral, popliteal, tibial and dorsalis pedis were feeble. There was radiofemoral delay which was appreciated. JVP was not elevated. There was no peripheral signs of infective endocarditis, no joint deformity. There were no webbing of neck, low set ears, or broad chest. Cardiovascular system examination. There was a positive findings ejection systolic murmur, which was present in the aortic area, radiating to bilateral carotids, right more than left, with the interscapular area and interscapular area. There was pansystolic murmur heard over the apex, and there was a pansystolic murmur with a bruit present over the bilateral axial area. There was loud second heart sound with ejection click heard, and apex was palpable 1 centimeter lateral to the midclavicular line on the 5th intercostal patient. Chest examination, there were normal vesicular breath sounds bilaterally, abdomen was soft, thyroid and breast was normal. So this is a primi gravida with a feeble pulse, lower limb pulse with a differential BP and with an ejection systolic murmur in the aortic area and a pansystolic murmur radiating to the interscapular area. So the probable differentials which you would like to consider will be. So first one with a radiofemoral delay, coarctation of
the presenting symptom was Osborn.
She came just for a routine antenatal checkup. She was asymptomatic at presentation.
She was asymptomatic, and you found that there was a differential blood pressure. What is the blood pressure in the upper limb?
So upper limb was 120 by 70 for the upper limbs.
And the lower limb blood
pressure? 90.
Okay, so did you look for any other sign of the radiofemoral delay?
It was present. Radiofemoral delay was there.
What other clinical signs did you look for to try and find out is there a coarctation of the aorta?
So one is
any other clinical signs?
The Sussman sign is there, in which the patient bends down and you can see the collateral.
You see or can you feel?
You can feel.
Feel. So you have to put your hands over with your palms over the interscapular area and look for palpable pulsations. And what does that indicate, Sussman sign?
So there is a prominent collaterals which have been developed, and it's a shifted coarctation.
Yeah, so collaterals are coming from the upper part of the circulation, from the arch of the aorta, the branches, and they're going to supply the lower limbs. So what are the symptoms of coarctation of the aorta?
Sure. So they usually present with a carotid.
Symptoms of coarctation of the aorta.
So one will be if there will be
so if there's no blood supply to the lower limb, what symptoms will people come in of?
Really, because of less blood flow in the upper limbs, and if in the upper areas of the vasculature, there will be headaches, epistaxis. There is a decreased blood flow in the lower limbs, so they will have a claudication pain.
So claudication pain is the main symptom. Person may be otherwise asymptomatic, and if you don't look for the radiofemoral delay, you may miss the diagnosis. But what clinical findings here are not suggestive of a coarctation of the aorta?
So one is the differential BP is not more than 30 mm mercury. In this case, which is just equal to 30 mm. And the peripheral pulses were palpable, but it was feeble.
Yeah. So
Collaterals.
what about the murmurs that this patient had? Very prominent murmurs radiating all over the axilla.
Yes.
Is that common in a coarctation of the aorta?
So one is yes, one if the so it depends on the aortic root diameter. If it is less than 2.5 mm, it will be an ejection systolic murmur heard in the aortic area. But if it is more than that, there will be a interscapular pansystolic murmur heard in the interscapular space radiating. So that will be if it
So
is
the
severe.
collaterals itself can produce bruits, which can be heard over the back also. We can get in coarctation of aorta. So do you think this is an inherited or an acquired coarctation?
Uh,
What are the causes of acquired coarctation?
so one is Takayasu arthritis.
Takayasu. So do you think this is inherited or acquired?
So she didn't had any autoimmune symptoms, and she didn't had any associated any history suggestive of Takayasu.
Okay, proceed.
There is no hypertension in the upper limb. Upper limb BP was normal.
Yes.
That is
there
a
was
bit
no
odd.
hypertension.
Yeah, that's a bit odd for a coarctation. The other
Yes.
physical finding you mentioned, ejection click, that suggests that he has a bicuspid aortic valve.
Yes.
Okay, so that's a common association. So the presence of an ejection click would favor a congenital coarctation because the bicuspid aortic valve is a congenital anomaly. So two things hang together. Okay, but absence of hypertension in the upper limb, how do you explain that?
Yes, sir. So as the so basically most of the individuals are asymptomatic, almost 20 to 40 to 50%. The thing is, once the adult type of the coarctation is usually asymptomatic because they develop collaterals by the time they reach that age group. The symptomatics are mostly the neonatal.
Upper limb hypertension, lack of it, is it because of a pregnancy?
So in this case, because of the development of collaterals, the blood pressure has been normalized. But pregnancy, as per se, I couldn't find any source which.
Maybe you should look at a pregnancy causes vasodilatation, right?
Yes.
Okay, so that might modify the blood pressure. I don't know. I'm asking a very ignorant question. Just look it up.
So,
okay.
Yes.
Okay.
So one thing is that during pregnancy, the cardiac output is increased and peripheral vascular resistance is decreased.
That's what Dr. Sheshadri is saying.
Progesterone and
So what happens to blood pressure in a coarctation? So in pregnancy, that's the question that Dr. Sheshadri is asking, because it's very uncommon to have a coarctation without a high blood pressure. Yeah.
Look, I don't know the answer, but I think it was looking up. Okay. All right.
Yes.
Okay. You can proceed. Yeah.
Yes. Other differentials which can be considered will be infection-related syphilis, which will be mostly involving the root of the aorta, fourth atherosclerosis of aorta.
That doesn't produce coarctation. Syphilitic aortitis does not produce coarctation.
So that would produce an aneurysm, right? Syphilis. More often it's an aneurysm. There is no narrowing, but it produces an aneurysm, right? Okay.
Yes. So investigations, the echo finding showed a bicuspid aortic valve with no aortic stenosis and a postductal coarctation with a peak systolic gradient of 43 mm mercury. The aortic root dimensions, the arch of aorta was 21 and abdominal aorta was 18 mm. And blood investigations with a EF of 59.4%. The investigations were all normal. Syphilis screen was negative.
I must compliment you on picking up a coarctation just on clinical examination in an asymptomatic pregnant woman. So I think it's a very good thing that you have done, and keep it up. Keep palpating lower limb pulses so that you don't miss, silent disorders. Right?
So the ECG finding of this patient which is actually normal. The usually coarctation of aorta, we will see a LVH pattern with LV stain pattern. However, in this patient, it was there was no LVH finding. So I'll be discussing about coarctation of aorta. So it is a narrowing of the descending aorta located at the insertion of the ductus arteriosus, just distal to the left subclavian artery. There are different types which I'll be coming upon, and it comprises 4 to 6% of all congenital heart disease, and most common site is juxtaductal. So this is there'll be a narrowing of the ligamentum arteriosum, following which there'll be increased pressure on the pre-arteriosal area that involving the subclavian brachiocephalic trunk, causing higher pressures in the upper limb, and lower limb there will be decreased flow, causing the lower pressures, which translates as a feeble pulse in the lower limbs, and decreased blood pressure, causing a differential BP between the upper and lower limbs. So other manifestations of diffuse, so it can also present in abdominal aorta as well. Coarctation after the most common complication is aortic dissection, aortic rupture, aneurysmal rupture, coronary retinal vascular, and other radial brachial carotid abnormalities, and systemic hypertension. So the pathophysiology, how does it develop? Is there are two theories. One is ductal theory and one is hemodynamic theory. So the ductal theory states that there will be a normal. This is a normal migration. There's a normal smooth muscle, ductal smooth muscle present in the ductus arteriosus area. However, if there is a migration of these ductal smooth muscles involving the arch of aorta as well completely, following the birth, there will be constriction of this area, causing the coarctation, causing the narrowing of this area. This is the one ductal theory. Second, if there is a other coexisting lesion like VSD, PD, or LVOTO, left ventricular outlet flow tract obstruction, there will be decreased blood flow in the outlet area, causing reduced blood flow, causing a constriction of the at the site near the ductal area. So whenever there is a coarctation of aorta, clinically we should also hunt for other abnormalities. So the most common type, so only 20% occur in isolation. So when you should also check for a bicuspid aortic valve, which is actually present in 50% of coarctation of aorta. Other extracardiac manifestation, barianeurysm, is just 10%. So always when there is coarctation of aorta, you should also look for other pre-existing lesions, which is like VSD or a PDA as well. So the clinical features, so mostly in adult, it will be asymptomatic when they reach adult. The most symptoms are present in the neonatal or early fetal life. So usually because of the presence of the collaterals, and the diagnosis is often made as an incidental finding because of hypertension. And the clinical presentation, they will come as headaches, epistaxis, claudication, and shoulder girdle pain. So the normal findings, I have differentiated normal and abnormal findings in pregnancy. So however, in pregnancy, dyspnea, orthopnea, pedal edema, palpitations, and syncope is a normal finding. However, if there is progressive dyspnea, nocturnal cough, PND, exertional syncope, or angina, should be alarming, and we should look for other cardiac abnormalities. So the physical findings in a coarctation of aorta will be, one is differential blood pressure, the difference of more than 20 mm mercury in favor of the arms, and it is clinically it's palpated with a radial or a brachial with the femoral with side by side. And the difference actually clinically which we can appreciate is if it is more than 20 seconds delay, milliseconds, we can appreciate. However, if it is more than less than that, it is not appreciable. But the difference of the delay of 15 to 20 seconds, more than 15 seconds is what a radiofemoral delay is. However, which we can manually appreciate is more than 20 seconds. The fundoscopic examination also plays an important role. It will show a corkscrew tortuosity of the retinal vessels. So if there is a hypertension in both the arms, the coarctation is proximal to the left subclavian. And if there is a clinical finding of coarctation, you should always look for an ejection click, which states that there is a coexisting bicuspid aortic stenosis. So the physical, if the brachial pressure is diminished or is equal to femoral pulse, the coarctation is distal, and the typical murmur is a systolic murmur, which is heard in the left infrascapular area and under the left scapula. And severe coarctation, it will be a continuous murmur because of the presence of the multiple collateral vessels. And this is the Sussman sign, which on bending of the patient, there will be prominent vessels which can be felt. So clinical findings in a normal pregnancy will be a laterally displaced apex, a loud S1 split S1 S2, S3 ejection systolic murmur in left sternal edge, slightly elevated JVP, continuous murmurs, which is a venous hum or a mammary shuffle, hyperdynamic apex, and pedal edema. However, any diastolic murmurs or S4 is an abnormal finding in a pregnancy. So this is the hemodynamics which occurs in pregnancy. So because of the increased estrogen and progesterone, there will be a decrease in the peripheral vascular resistance. And it has been found that in second trimester, there is increased cardiac output. So the overall blood pressure is reduced. because one of the hormonal influence, and second is the increased sympathetic activity. And there is also a plasma hemodilution in pregnancy. So this is a article which actually showed suggest there is at second trimester there is a increase in cardiac output and a decrease in peripheral vascular resistance, thereby reducing the blood pressure. So in echo finding,
she presented in which trimester?
So she presented in second trimester.
Okay.
So echo finding, you will have a severe narrowing at the descending thoracic aorta, and there will be a associated bicuspid aortic valve in the parasternal short axis. So coming to the ESC guidelines of management of coarctation of aorta in pregnancy. So class 4 recommendation is contraindicated in to continuous pregnancy. Coarctation after repair it comes in class 2, WHO class 2 risk. So if there is any significant coarctation, it should be corrected before pregnancy. There is maternal and obstetric risk. So the maternal risk, there will be increased risk of rupture when there is unrepaired native coarctation or any residual hypertension, any aortic aneurysms, dilatation or bicuspid aortic valve, which can lead to rupture of cerebral aneurysm or aortic rupture. So obstetric complication will be hypertensive disorders or miscarriage. So management is there should be a close surveillance of BP and there should be regular follow-up at every trimester, and hypertension should be treated. However, aggressive treatment should be avoided to prevent any placental hypoperfusion. So the antihypertensives indicated in pregnancy, the first line is the labetalol, and in CCBs are also nifedipine is the preferred. However, ACE-ARBs are avoided. So in case of recoarctation of aorta, so after repair, if there is recoarctation, there is high risk of aortic dissection. The percutaneous intervention should only be performed in two conditions: when there is maternal or fetal compromise, or there is severe hypertension despite maximal medical therapy. And delivery, there is no particular weeks or guidelines which says that delivery should be done in particular week. Spontaneous vaginal delivery is preferred. However, if there is any obstetric indication before that, it can be induced and can be terminated. However, the preferred some articles suggest that 37 to 39 weeks is a safer time for delivery. And in case of aortic stenosis, the only indication for intervention is if they are symptomatic, and second, there is LV dysfunction less than 50% is present. And if the exercise stress testing will show
in the interest of time, could you tell what you did for this patient?
So currently she underwent a coarctoplasty, and following that repeat echo showed a significant decrease in the systolic pressure gradient, and her upper limb pressures actually improved. The differential pressures improved. Second is she's been planned for a follow-up, and MDT has been arranged, the cardio and
could you just explain what coarctoplasty is?
So basically we dilate the area of the coarctation with a stenting, or a balloon angioplasty is done, either of these, and to increase the flow.
So she tolerated the procedure well?
Yes.
Okay. She's under follow-up.
She is under follow-up
now, and her blood pressure has not gone into the hypertensive range.
Yes.
Yeah. Thank you, Osborn. Any comments on this case? Sir, do you have any other comments?
In the presence of a bicuspid aortic valve, she goes for delivery. You might require prophylactic antibiotic. Do you think?
Yes, sir. Infective. I look
at it. Is it a congenital defect today?
There is no in this echo finding. There was no aortic stenosis. So if
no, bicuspid aortic valve per se can be a focus for infective endocarditis. You need to keep that in mind. Even though it is asymptomatic, maybe an indication for prophylactic antibiotic. And if she's going through a normal vaginal delivery, might have to cover gram negatives. Okay.
So the guidelines for IE prophylaxis in congenital also has changed. So the high risk ones are the ones which are like VSD, PD8 TOF, all require prophylaxis. But the bicuspid aortic valve requires prophylaxis is something that you should.
Just look it up. I think maybe guidelines have changed, but I think keeping that in mind. Yeah.
Thank you very much, Osborn, for your very interesting presentation. We have the next case is by Linu.